and welcome to History in Lowell. I'm Maritza Grooms, your hostess with the mostest, and I'm here with my best friend and buddy, Bob Forrant, Lowell's favorite history.
Good morning.
And we have a very special guest today, Dr. Tello of the Greater Lowell Health Alliance, the Community Health Data Manager.
That's right. Yes. Good morning. Good to see you both.
Awesome. Thank you so much for joining us today. So, we're going to be talking about the hot topic of the last few months, racism being a public health crisis.
That's right.
We've had lots of anecdotal stories and lived experiences where we've heard people's stories, and, we've even delved into the history of Lowell's history of how racism has impacted public health. But, sometimes the numbers really, really helps, So Hannah, you're going to help us kind of wrap our brains around this in a different kind of way. So
Sure.
Take it away.
Great. So I've been thinking about how to frame this for History in Lowell, and I decided that we're going to start with history, which isn't always a data manager's favorite place to start, but we're gonna do it. All right. So like you said, this is the hot topic, right? We've got hashtags, we've got movements, it's branded, and like people are hopping on board. But it's not especially new. If you've worked in the field of public health, the idea of racism as a predictor of health outcomes isn't especially hot or new. It's just that we have different people, more important people, listening right now than we have in the past. So in terms of race and health, I think it's important to understand where this research is rooted, to understand why it's taken researchers so long to figure out the right way to talk about this. So going way, way back in terms of what race research was in health, is that we were primarily white researchers were looking at differences between races as a way to establish biological roots of white supremacy. That is where race research in health is rooted. That is our history as health researchers. So we were doing ridiculous, like even the way we ask the research question even is going to frame exactly the type of findings people were finding. So they were looking at differences, but what they were really looking at were differences that justified this idea that there was one color of person that was inherently healthier, better, going to be more successful than another color of person. And it took a very long time, at least decades, if not whole centuries, for someone to finally say, wait a minute, there's absolutely no mechanism of action that would make melanin a critical determinant for this range of health issues. There's a few very, very specific diseases that we do see kind of an ethnic or biological root, but that's a very short list compared to the grand sweeping things that people were trying to say race was a determinant. So there's nothing about melanin that means a woman is more likely to die in childbirth. There's just no mechanism of action that would justify that. So around the late 90s, early 2000s is when public health started to change the way they were asking questions. And we switched from talking about race as a predictor of these things to talking about racism as a predictor of these things. Because we also saw that all of the things we were saying were happening to, for example, Black women in the United States were not happening to women in Africa, that they were not having the same negative outcomes as our Black women here. So our whole history of saying that this really had to do with race, that this was about some genetic or ancestral something, turned out to be complete nonsense. So we only arrived at the ability to even frame the question in the right way in the late 90s, early 2000s. But once it did, it certainly took off. And now any paper, any research that is looking at race is going to be interrogated for why are you asking about race and making determinations about race and not about racism. So while I get that we're doing some onboarding now with people who are new to it, it's certainly not new. And it's certainly not new for anyone who's been a Black scholar doing this work pre-1990s. I mean, people were having these discussions for a really long time. It was just a matter of people in charge deciding to listen. And it took them quite a long time. So now we're at that stage. But the good news is we do come armed with the onboarding with a little bit of research already done to try to help people get on board gently with data, with science, that the idea that racism is a significant predictor of health outcomes. And when we see racism at the scale that we see it, as it's embedded in our culture and in our systems, then it becomes public health. It's not just about one person's individual health or one person's individual exposure to racism. We see it at a scale that requires public health to declare it a crisis. And by and large, public health has.
It's also, I mean, in terms of the history, it's really fascinating because you go through all that history and then you say in the late 1990s, early 2000s, which means for century, for 2 or 3 centuries, like the AMA and these very famous medical journals or whatever, were doing this for 150, 200 years, right? So when you were summarizing, you said the 90s, I was thinking, oh, in the 1890s, maybe?
Oh, I wish.
Right. I mean, so it's
No.
really, it's quite stunning, right? I mean, the other thing that I think about, again, from the historian's perspective, is when we do research now at colleges and universities, it's called human subjects research.
Mm-hmm.
And we have an institutional review board that's supposed to approve our research. One of the reasons why that came about is because medical experiments were being conducted on African Americans, on prisoners, on poor people, all the time without telling anybody. They were being injected with a disease, they were being given an experimental drug or whatever it would be, and eventually people began to uncover it. So is that part of what you're describing in terms of the way things sort of work, the way people, the racism is sort of embedded in the practice of medicine in a very profound way?
It is. And my main area of interest is in maternal and child health. And frankly, there's no better, more disturbing example of this than in the history of obstetrics, in which a huge amount of our medical interventions that we use in obstetric care started as unauthorized, non-consented, unanesthetized experiments on pregnant Black women. There's, in fact, right now, a pretty big movement there's a specific obstetric tool that can be used as an assistive device during birth that was developed by a doctor who very proudly used it and experimented on pregnant, laboring Black women, and the tool is named after him. So there's a big movement in obstetrics to identify, name, and remove the very obvious. I mean, there are things that are insidious that impact practice that are racist, and then there are just in your face, glaringly obvious, impossible to ignore things that we can do to say we're not going to honor people who created our field based on abuse of particularly Black women. And I think that, one of the challenges is that, we say like, oh, well, in our field, like we're now learning about these things. And that's not true. In our field, we've ignored these things. And that's different than someone saying, oh, here's this big revelation you can have. No, we may have inherited an ignorance of it, meaning there were certainly people who knew what this man was doing to Black women when he was doing it. And maybe we weren't there. This is generations ago. But we certainly inherited a willful ignoring of abuse and of harm. And this is just an example of an obstetrics. You can go in any field and see the similar examples of abuse. So we do have to be accountable for that in the really obvious ways, and then the more insidious ways that racism impacts service delivery, specifically in a medical setting.
Yeah, I mean, I had done some work with some students on Latinx women, and particularly Puerto Rico, where so much forced sterilizations, women would have a child and then they would wake up and they would have been sterilized. No consent, no anything, just do it. And it really has its roots also in the eugenics movement in the early 20th century in the United States, where that was a common practice as well, experimental and whatever, right? So it sort of backs up and reinforces more what you're describing, that people are aware, but let's not rock the boat. Maybe I want to advance in my position to a better job in X hospital, and the boss of the hospital is doing X, Y, and Z. I better not say anything because then I might, not get the promotion I want. And so we participate. What you're saying, I think, is we participate knowingly, sometimes not knowingly, but in the end, it's not like we should be surprised.
There's a complicity there. And then I also think about how far the history goes back, because the things that I learned about what happened to enslaved women so long ago sounds just like this kind of abuse that was continuing, and to Indigenous women, and the sterilization of Indigenous women as well. And then I think of how this is just continuing now, and we look at even famous people, right, with money, and like, I always have to bring up my girl Beyonce, but also Serena Williams. You know, they both almost died in childbirth, and they had to. Their money didn't save them. Their money couldn't save them.
And I think that's a really important point, because the history of something like the really horrific history of obstetrics, it is important to know it, but it's also important not to let people look at just the most horrific parts of racism and say, so we just have to make sure we don't enslave and abuse people. And yes, we do have to make sure we don't enslave and abuse people, but that is the lowest bar possible in terms of dealing with how racism impacts health. So things like what we see a lot is people saying, well, when we say race, what we're just using that as a proxy for poverty or income. And we know that being poor in the US means that you are going to have a less healthy life, which is true. And to be fair, we shouldn't accept that either. The fact that this is more palatable to people, that poor people should be less healthy, and that's okay, but we don't want to say that race makes people less healthy. That's another talk. We can talk about that a different time. But we actually know, using data, that race is not just a proxy for poverty. That what we know is that racism can exacerbate the negative impact that poverty has on health. It can make it worse, but that income and wealth and education cannot eliminate the effects of racism. We have plenty of studies that look at this in different contexts. So then for a researcher, the question becomes, why, right? Because the next reason people are resistant to this is because it doesn't make any sense. Like so we talk about a mechanism of action, meaning why does this thing cause this negative outcome? So why does racism do this? And there are really three pathways that racism causes public health crises. So one is physiological, that when we are looking at things that cause negative health outcomes, a vast majority of them fall under the category of stressors. So things that put stress on the body and create allostatic load. So the stress that includes, increase in your heart rate, you have a cortisol response, and all of that stuff causes damage to the body. It turns out when we have one really stressful incident, so you get in a fight and you feel stress and then you calm down, those things, it turns out, we want to avoid them, but it turns out it doesn't cause as much lasting damage on the body than a chronic stressor. So poverty, one way that poverty causes poor health is that poverty is, in the US, a chronic stressor. It is hard to be poor in the US. Racism is another unique chronic stressor. So that even if a person doesn't have one explosive incident that has something to do with a racist attack or something like that, that doesn't matter so much as the fact that that person has been exposed to the chronic stress of racism over the course of their lifetime. And that causes damage to the body that results in stress-related illnesses. So things like heart disease. This is also probably a mechanism of action that is related to preterm birth and very low birth weight babies. And that is physiological. It is a biological fact that exposure to chronic stress of racism hurts the body. And we also know that it does appear to be dose dependent. So people who grow up in insular communities where maybe they're not exposed to systematic racism at the local political level, et cetera, tend to have slightly more protection, but not very much, because we can't escape racism in the US. There's no real place where you are insulated from racism because it exists at a system level. So you have to live totally outside the system to be protected from it. And that is very hard, if not completely impossible and unrealistic to do. So there's a physiological mechanism, but then there's also the lens through which racism impacts the way we describe health behaviors. So working in maternal and child health, for example, one of the biggest recommendations for a person who's looking to, for example, avoid a negative birth experience is to advocate for themselves. You'll read 23 pages of data, and then there'll be one little paragraph for recommendations, and that little paragraph says we should teach moms to advocate for themselves. However, providers view advocacy through a lens that was developed in our society, and our society has racism as a problem, right? So when providers see one patient asking a lot of questions, declining procedures, asking for a second opinion, one person gets labeled as, wow, that person is really advocating for themselves. Another person doing the exact same behaviors gets labeled non-compliant. They become a difficult patient. They may receive poorer care from that provider. And oftentimes that discrepancy is based on race. That there are certain people for whom advocating for themselves is safe and they'll be okay and they won't experience consequences, but we can't guarantee that for everybody. So it's pretty reckless to recommend that. And we do that with a lot of health behaviors. The way we label them is loaded. When one person does it, I mean, we saw this in news coverage of people who were looting versus people who found supplies in a disaster. So there are tons of examples of how risk behavior or health behavior is viewed through a lens. And then racism impacts the workforce, right? So we're talking about health, so we're talking about caring professions, and caring professions at the top, at least, are very much positions held by white people. Now, the lower you go, so when you're looking at the front lines, we see a lot more diversity, and that is one of the things that might be explaining locally. We're seeing the effects of COVID-19 disparately in our community. So we're seeing a higher disease burden in our population of Black and African American community members. One of the reasons is that the very, very frontline healthcare workers, LPNs, CNAs, people who do home visits, those tend to be tasks performed by people of color. People of color in the caring labor workforce also tend to interface with more patients. So a doctor may see a small handful of patients a day, but a nurse is going to see exponentially more than that doctor sees, right? Like her caseload is going to be larger. And frankly, the lower you go, the bigger the caseload gets. And that level increases your risk of exposure. So those types of things in the workforce, where the higher up the ladder you go in any caring profession, the whiter and whiter and whiter it gets. And then at the bottom of the ladder, you see much more diversity. And at the bottom of the ladder, you also tend to see lower incomes. You tend to see higher risk positions where you're having more exposure. So those are all ways that racism is related to public health, and public health really needs to intervene at each of those three domains where we see racism impacting healthcare.
So it's interesting that the wages, as you were describing the sort of a pyramid, the people doing the most work and the most at risk and the most at contact with potentially, in this case, COVID carrying patients and what have you, they make the least money. So we have this, again, we have this really interesting economic function, right? Where the person that sees the patients the least makes multiples of the same wage that somebody below. And the other thing I think, if this makes sense in terms of the way you are thinking about this, the persons of color are more likely also to be in fast food, grocery store, other sorts of work where they're also in daily contact. So it's interesting. We've created this imagery. We're all in this together, and we're all heroes, right? To sort of lionize these folks. You don't give them more money. You don't give them health. They don't get health insurance. They're still treated as badly as they were treated before. Now they have to bear the burden of telling people to put a mask on, which seems to me their workplace itself, using your language, is, I would assume the workplace environment is one of these stressors that you're talking about that's chronic over time, right? And so that increases potentiality for people being sick as well. Is that a fair?
Oh, absolutely. I mean, I think it's one of the things we always have to be careful of when we're creating noble professions. So care work is a noble profession. Teaching is a noble profession. Police and fire are noble professions. And in some of those, not all of them, being a noble profession means that we protect it from criticism because it is so noble. And not just from the outside, right? Like people looking out saying, that's not okay to treat your worker like that. but it happens on the inside, right? Workers also internalize the fact that part of the reason they chose the job that they did is because it is selfless. There's social capital that's gained from choosing a noble profession, right? There's things about you. There are certain professions that your parents are going to be proud, right? There's certain professions that people are going to say, "Good for you," right? And that matters to people. That's a type of capital that people care about. So when we enclose them in this language of nobility, it means that we absolve responsibility for caring for those people, for ensuring that they're being paid, for ensuring that they're being protected, because part of the social contract of choosing that job was, well, you're going to suffer a little bit, right? Like that's part of that it wouldn't be noble if there wasn't suffering. And too often that suffering is delivered through poor wages, poor conditions. And now we're seeing a significant effect of that with coronavirus, with COVID-19, because people in those noble professions aren't divvied out evenly across all racial groups. There's certain noble professions for certain people and certain ones for others. So we're seeing the effect of the cost of allowing noble professions to be absolved of responsibility for caring for their workers now. And unfortunately, it's at great cost. It's a deadly cost. And we're going to be dealing with that for a long time. So as we're thinking about why are we talking about racism as a public health crisis, there's no more important time than right now, as we are dealing with a pandemic that is not, the disease burden is not equal across all groups. There are people who will pay a higher cost, and we should have been ahead of it a long time ago. We're working from behind. So people can get on board or not, but as a public health professional, this is the angle that we will be doing the work from, whether people are on board or not. So you can join and help, or just step out of the way at this point.
Yeah. And that brings me back to your first, I think it was the first mechanism, right? Advocacy, right?
Mm-hmm.
And patients having to advocate for themselves, but also Black and brown folks in the front lines having to advocate for better wages or better work hours. And it also brings me back to Lowell's history, right? Of the mill girls having to do the exact same thing for their own health and well-being. Imagine working in a place where there's dust everywhere. We won't go there, but but you get what I'm saying. Like, you get where
they
I'm
didn't
going.
have masks.
Yeah,
They
no
didn't have
mask.
masks. There was no ventilation, right?
Yes.
And I think about like the stressor that comes with having to advocate for yourself in a community care setting, in these noble professions, and the added stress that comes with that, right? And then the racism that's there. And then I think about something, because, being at home, you tend to be online a little bit more. And I've seen this thing circulate. Black women, use this when you go to the doctor. This is how you advocate for yourself. And we're doing that in 2020. This is, you have to do it in this way so you don't come off this way, and make sure that you ask them to write it down that they denied you this care, or
Right.
whatever the case is. And then we have to constantly document everything. And I just think that it's a lot. It's a lot. It's a very heavy.
It is a lot.
Mm-hmm.
It is. And I think that that's one of the important things about knowing what the work of public health looks like, is that there are things that we have to tell people to do now because they're in danger, right? Like, research takes a long time, and it takes a long time to get, the people at the top on board. They're slow. They like to take their time. Like you said, we've already shared individual stories. We have local data. And yet we're still working, we're still onboarding, right? So we need to make sure that we're not only doing these immediate safety interventions, right? So teaching Black women, say it this way, do it this way, has to happen, because that person's individual health is on the line, right? And we can't say, well, yours is, it's going to take us like 3 years. So in the next 3 years, people, good luck, like, you're on your own. So we have to do that, but we cannot possibly allow ourselves to say, okay, we did public health, or okay, we solved the problem because we gave people individual strategies to reduce the likelihood that they'd be denied care, or reduce the likelihood that they'd be abused, or reduce the likelihood that they die in childbirth. That cannot be what we're okay with in terms of saying we successfully performed an intervention, right? So while we need those things to happen, we need to, because we talk about this as an issue of racism, I think we really need to be talking about this as an issue of white supremacy, because it's a white issue, okay? It's a problem of white people. Black people are performing the labor of fixing a white problem. And we've allowed that to be the way that it's been historically for a very, very long time. So we need to start changing the language about it a little bit to deal with this is really an issue of white supremacy. So at that outer level beyond the individual, that's where I try to orient my work, because there's a lot of people doing good work at that individual level. And frankly, it's not usually white people. These are communities who are figuring out solutions for themselves. And historically, Lowell has seen this at a much larger scale for a very long time. I mean, one of the biggest assets of this community is the degree to which members of communities will organize to solve a crisis when it's necessary. And that is an asset, but it shouldn't have to be an asset at all, right? Like we shouldn't have to rely on communities that are being oppressed or that are experiencing crises to be in charge of all of the efforts to solve them, right? They should be happening there, but also all the way up the ladder to the top, right? We have to relieve some of that burden. Lowell understands this better than a lot of cities. I mean, a lot of the organizations that we see today, their origin story was very, very community-led, very bottom-up effort. And they emerged because they had to, because there was a crisis or an unmet need that had to happen. Now, and then over time, you kind of get away from that, and we got to shrink it back down every now and then. But that's where it happens. And I think that generally in public health, when we're talking about, we need to talk about racism as a public health crisis, what we're really saying is we just want to get a little bit more upstream. Like we just want to move our interventions a little bit further up so that we can try to prevent people from falling into the river of poor health outcomes at all. And we're tasked with doing this all the time. It's a very buzzy, popular thing. We want interventions to move upstream. It's in every grant ever. This is such a tangible, meaningful way to do exactly that. To deal with racism is to go to the very top of the stream and say, we can do so much up here that will help downstream. And that's the reason why it's so important to get leaders onboarded with this, because a lot of what can happen upstream has to happen through leadership. The GLHA works largely with people who are frontline, who are people who are working downstream because they have to, because there are people drowning in that stream of negative health outcomes. So somebody has to be there pulling them out, right? So our effort to ask for onboarding leadership is really saying, please just help us move upstream. We don't want to stop downstream. There's plenty of people doing amazing work in their community for the people downstream. We want to relieve a little bit of the burden for them by moving our efforts upstream to try to prevent what's happening as people experience things that we could have prevented them from experiencing. I don't need you to unpack your childhood or to tell me about your friends that you have. All of that is between you and a diary or a beloved friend. And what I'm saying is I have tasks, right? I have things we could do together that are the work of anti-racism. All I'm asking for you is to do that work with me.
That is great way to wrap this up. Thank you so much. I got to say, Dr. Hannah Tello, because you earned that PhD.
Thank you.
I think that it's really important to say that racial justice work should be at the core tenet of everything that we're doing, because then we can all be engaging in that anti-racism work and making the world a whole better place for all of us. Imagine white supremacy impacts all of our lives in a very negative and detrimental way, and not just Black, Indigenous, and people of color. Everybody is negatively impacted by this. The numbers show it, and our lives show it. So we can make the world a better place, maybe.
Definitely.
Yeah.
Yeah.
So thank you for being here with us. Thank you, Bob. And thank you all for tuning in. This has been History in Lowell.